Hi, this is Pam from Your Nurse Advocate Consulting, and welcome to Tuesday Tips. I'm so glad you're joining me today, and this is really kind of an important live session. This was probably one of the most urgent. I mean, we've had some cases that have required some um, pretty immediate intervention on our part. So today we're going to talk about a topic that affects, really so many families, but often flies under the radar, and that's medication errors that occur during transitions in care. And what I mean by transitions in care is whether you're coming home from the hospital, moving to a rehab facility, or helping a loved one settle back in at home, these transitions, are prime times for medication mix-ups. And let me tell you, these mistakes, really can be dangerous, even life-threatening, or cause a readmission back to the hospital. That's the last thing your aging loved one wants to do is once they get out of the hospital, all they can think about is going home. And the last thing they want to do is have to go back. But the good news is, with the right knowledge and a little advocacy, we can prevent those. So to show you exactly how that plays out in real life, I want to share a story from my own experience recently as a nurse advocate. This is a true story. It's a perfect example of why speaking up matters. And so let's introduce you to Mary. Mary is not her real name, but her story is real. So Mary is 85 years old. She was admitted to the hospital with a diagnosis of congestive heart failure, along with a few other health concerns that all made each other worse. While she was there, her cardiologist decided to start her on a new medication to help her heart, her blood pressure, and the congestive heart failure. Felt it was a good overall medication. And at the same time, her routine blood pressure medications that she came into the hospital on were discontinued. So old blood pressure medicine stopped, and the cardiologist started a brand new one. And that's a pretty common scenario: new diagnosis, new medications, changes to the old ones. Nothing out of the ordinary there. That's totally routine. But a few days later in the hospital, something, concerning happened. Mary's blood pressure dropped dangerously low. The care team quickly stopped the new medication and had to intervene with some treatments to bring her blood pressure up. She had to get some IV fluids. She had to get albumin, which, is a volume expander to kind of increase the volume of her blood to help bring that blood pressure back up. And, once things stabilized, they held all of her blood pressure medicines for a couple of days, but then after things stabilized, they restarted her on her original blood pressure medicine, the medicine that she came into the hospital on, the one that she'd been tolerating well before hospitalization. So far everything, is going, as planned, is pretty routine. But let's fast forward to her discharge. Mary went home, and we participated in her follow-up appointment with the cardiologist. Mary had us on her cell phone on speaker, and we participated in her follow-up appointment with her cardiologist at that time. So here's where things got tricky. So the cardiologist immediately wanted to know who stopped, that new medication, and that the first thing he wanted to do was to put her back on that new medication, insisting that it wasn't the cause of her low blood pressure in the hospital, and he believed it was actually the old medicine that was to blame. But here's what he missed. He didn't realize that her old medication had been stopped when the new one was started in the hospital. He saw it still listed in her records and assumed she'd been taking both at the same time, when in reality she hadn't. So I strongly disagreed with this assessment and asked him to review the hospital notes. I wanted him to look and see, read from a doctor. Don't take my word for it. Read the doctor's note from the hospital on why they discontinued the new medication, and then, come to a conclusion. And so after a bit of back and forth, he really reluctantly agreed to hold off restarting the medication for now, he said. And he said we would pick up the conversation on her next appointment. Mary was understandably scared to try the new medication again. She did not want to try it and to go back on it. And after our discussion, like I had mentioned, the cardiologist did agree to hold off on restarting it. You know, this story is really kind of a powerful reminder. Even the best doctors can make mistakes, especially during transitions of care when you're going from hospital to nursing home and so forth. And we're taught to trust our healthcare providers, and we should. I've worked with amazing doctors in my career, and we're all human, and we need to remember that. So it's really important to speak up, ask questions, and double check everything. Obviously, my disappointment was that he didn't review the hospital notes when her discharge. All he would have to do is review her discharge summary, and he would have seen that they would have stopped this new medication and put her back on her old medication. And he would have had the most current information coming into now her follow-up appointment after being discharged from the hospital. So Mary was able to avoid a potentially dangerous medication error and possibly another hospital admission because someone was there to advocate for her and make sure the details weren't overlooked. And so this was the important part, is that we really do need to keep an eye on these things because, and we're going to talk a little bit more as we move on about that. So why medication errors occur during transition. So what are the risks of that, and why so many? I mean, 65% of medication errors in the healthcare system occur during transitions in care. And so that's over half. So why are transitions like leaving the hospital or nursing home to home so risky for medication errors? Well, a few things. Number one, multiple people are involved. Hospitalists, which are the doctors that see the patients during their hospital stay. Oftentimes they're on for 7 days at a time. They rotate through. And so if you're there for a week, or if you're in there on a Saturday and through a Wednesday, you might get two different doctors. But hospitalists are doctors that just see patients on the floor in the hospital. And so you've got the hospitalists, you've got specialists, like in this case, there was cardiology, there was pulmonology, the lung specialist, the heart specialist, infectious disease doctor, so primary care pharmacist. Everyone has a piece of the puzzle, but sometimes the pieces don't fit together. So let's look at the next thing, medication list changes. New medications are started, old ones are stopped, dosages get adjusted. In this case, we had a new one started and the old one stopped. Then when the new one was stopped, the old one was restarted. So it's easy for things to get lost in translation. And it's clear, even the cardiologist wasn't aware of the facts that he needed to know before he was wanting to restart Mary, on the medication that caused the blood pressure issues. So medication lists can even change in the last hour of discharge, when all the healthcare staff are reviewing it for mistakes or omissions, that golden hour, that last hour before your loved one goes home. And you may think that you have the most current list at discharge, but you may not. Always ask when the last update or changes were made, and make sure you have the newest list hot off the press. So oftentimes discharge summaries and patient teaching summaries are printed and sent to the nursing home hours before discharge to allow the nursing home time to prepare, make sure that they're going to have all the necessary medications on hand when your aging loved one gets to the nursing home. So that can lead to some communication gaps. So discharge summaries may not be complete, and follow-up doctors might not have the latest information. So again, if the list is changed at the last hour, the pharmacist is reviewing last review before the patient leaves, notices a mistake or notice a wrong dose, the doctor, they change it, they want to make sure. But now we don't know if the nursing home has got that discharge summary now, since the changes have been made. So there's a lot of hands in the pot. It could be a discharge planner, it could be a case manager, it could be the social worker that faxes and gets these discharge summaries to the nursing home. So everybody's got to make sure that they're constantly making sure that the right information is being given to those that need it. So again, if the list is changed in the last hour, there's a risk that the nursing home did not get the most recent copy, and that's how errors can occur. And they use the discharge summary as their signed doctor's orders. Off in many states, doctors don't have to write out a list of orders. They just have it in their discharge summary because they sign that. So nursing homes can use that discharge summary as the orders to provide care. So if it's not on that discharge summary, they it's not an order for them, and they won't do it, or they'll give something that may be incorrect. So the result is medications can be duplicated, they can be missed, or even the wrong dose. And for older adults, especially those with complex health needs, these mistakes, could possibly have some serious consequences. So let's talk about 3 stages to avoid medication errors. So let's take a peek at that. So before leaving the hospital, the nursing home, ask for an updated medication list. This should include all current medications, the name, the dose, how often, and why it's being taken. And what's super important when you're going to another facility is when was the last dose given and when is the next dose due. Mary had a similar thing when going into the nursing home. They didn't not have all her medications, so she got her morning medications in the hospital. The hospital didn't give her afternoon medications before she went to the nursing home, and the nursing home didn't get her medications until the evening, so she missed her afternoon doses of medication. Perfect example of how things can fall through the cracks. Also, what's been stopped or changed and why? So has a medicine been discontinued? Has a new medicine started? Or has a dose changed? Or the frequency, how often they're taking it? Has that been changed? Know the new medications and what they're for. So you want to bring this list to every follow-up appointment and share it with every doctor involved in your care. If you see someone, I oftentimes see the MyChart is not up to date, when the patient comes home from the hospital. And so they may not have the current list of medications because it hasn't been updated in their end of the system. Or you may see a doctor provider that's outside of your system. And a lot of people don't understand that our EMR or electronic medical records, you could say a popular one in our area is Epic, but we've got Mayo, we've got Gunderson, we've got Toma Health in our area, and they all have a form of Epic, but they don't all completely talk to each other. And so people, don't understand that just, they think that if it's in the computer, everybody gets to see it. That's not the case. So it's very important. A good friend of mine, Barbara Gaynor with Braddock Consulting, is another advocate. She does a great workshop on a medical binder, having all your stuff in one place that you could take. Really strongly encourage, especially after a hospitalization, bring that most current medication list with you so that all the providers have the most updated information. Number 2, schedule a medication review with your pharmacist or your primary care provider. Within a week of discharge, schedule a medication review, especially if there's been a lot of changes, either with your primary care doctor or your local pharmacist. Ask them to double check for duplications. Sometimes if they have a brand name and a generic name, it could, you may think it's 2 different medications and it's really the same one. If there's any dangerous interactions or unnecessary medications, polypharmacy or having a lot of medications with an elderly aging adult can be a problem. And so a lot of pharmacists now are working with providers to really look at those and seeing what is absolutely necessary and what can be removed from that medication list. So a pharmacist is a great resource to help you in this arena. So don't assume everyone is on the same page. Sometimes you have to be the connector, and that's what we do as advocates. We keep the balls in the air. We keep all the pieces of the puzzle in place. We make sure all the healthcare team knows what's going on and everybody has the most current information. And, even we have a client right now who has a home health nurse. Her and I talk weekly because she's in the home. She picked up on a blood pressure issue, so we communicate so that we're on the same page because I'm advocating behind the scenes on other things that she's in there for wound care. So it really helps to have someone in charge of just, again, keeping all the balls in the air, so to speak. So don't be afraid to ask questions that you don't understand. Oftentimes, providers can speak in a language that the layperson doesn't understand. If a doctor wants to restart a medication you had problems with, ask them to review your medical records, your hospital records. Use phrases like, "Can you help me understand why this medication was changed?" Or, "Can we double check the notes from my hospital stay?" If you're not comfortable or feel uncertain, bring a family member, friend, use a nurse advocate, someone to help you navigate this situation. So, in starting to wrap up, what we want to do is, remember, medication errors are preventable. Now, we're not talking about allergic reactions to a new medication. That's, if you've never taken it before, there's no way that, we can predict, if you're going to have a reaction to that. But errors are preventable, but it takes awareness, it takes communication, and sometimes it takes a little courage to speak up. And I have a tendency to be kind of a shy, introverted person, but in nursing, I'm the mama bear, and I'm extremely comfortable speaking up when I need to. But that's because this is, after 40 years of nursing, this is my comfort zone. So, just make sure, if you're a little shy, like I have a tendency to been, have someone with you that's not afraid to ask a question, someone that will help advocate for you. So if someone you love is facing a transition in care, don't go it alone. Our team at Your Nurse Advocate Consulting is here to help you navigate these changes, ask the right questions, and make sure nothing slips through the cracks. So, if you found this video, if you're seeing, welcome. If you're seeing us live, thank you for being here. And if you were unable to catch us live and you're catching us on the replay here on our Facebook page, thank you for taking a peek. And also, we post the replay video on our YouTube channel, so it'll be there where you can catch that as well. So if you found this helpful, please share it with someone that might need it. And if you have questions or want more resources like our emergency to go folder checklist or tips for caregivers, just drop us a comment or visit our website. We're here for you. And thanks for joining me today. Stay safe, stay empowered, and remember, you are your loved one's best advocate. So we hope you enjoyed and found this week's Tuesday Tips informative, and we look forward to seeing you at a next Tuesday Tips. Take care.